So let's now start by the lens and the cataract. It is one of it is one of the most easy parts in the course and in the exam. So my students usually love this part. So let's try to have this more easy topic, trying to not to be more you are already taking a lot of topics the previous days, so this will be easier for you to catch up with what we discussed. So regarding the lens and the cataract, what is the scope of this topic? We will cover, first of all, the lens disorders and the cataract. So we will cover the lens diseases. Then we will cover the lens surgery. So today we are going to cover the lens disorders and the cataract, different kinds of cataract. And the next time we will discuss the lens surgery and the corneal surgery. So lens surgery, we will first of all discuss the preoperative assessment, then phacoemulsification, steps and procedure, and complications. So let's start immediately with a basic introduction of about some basic topics about the lens that I found to be useful for the exams that can sometimes be asked even in the clinical exam. Starting from very basic, the anatomy of the lens. So we know that the lens is composed of zonular fibers. These zonular fibers will attach the lens to the ciliary body, and then the lens is already enclosed within a lens capsule. The lens capsule is elastic, and it is thinnest and weakest around the central portion of the posterior capsule. See, the thinnest part is the lens at the center posterior capsule. The anterior lens capsule is thicker, and it is lined by single layer of cuboidal epithelium, which are metabolically active. They replicate, and they will give rise to new lens fibers. This metabolic process occurs at the equator. So the lens epithelium is cubical, and as it is migrating toward the equator, it is becoming more elongated. Then from the equator, this cubical lens epithelium will give rise to the lens fibers. The newest lens fibers will become superficial, while the deepest fibers are the older one. So these fibers are becoming compressed from the outside to inside to make the lens nucleus, which will be surrounded by the lens cortex. So the lens nucleus will be in the center, and peripheral will be the lens cortex. This is very quick overview of the anatomy of the lens. The embryology of the lens will be the lens that the lens is consisting of different kinds of nuclei, starting first from the embryonal nucleus. The embryonal nucleus, there will be the most central part. You can see it is evident by the presence of these Y sutures. These Y sutures sometimes can give rise to sutural cataract. That's why we are discussing that. These Y sutures are present in the embryonic nucleus, which is formed in the first 2 months of gestation. Then there is the fetal nucleus. The fetal nucleus will be surrounding the embryonic nucleus, which will be formed in the last month of gestation. The infantile nucleus will be surrounding the fetal nucleus, and it will be starting to form from the last month of gestation till 25 years old. After 25 years old, there will be the adult nucleus. The adult nucleus will continue for the entire life after the age of 25. Another also important thing that we mentioned in the pediatric retina, that during embryonic life, there will be a system of blood vessels that will supply the developing lens and anterior segment coming from the hyaloid artery. It is called the tunica vasculosa lentis. So the tunica vasculosa lentis is a network of blood vessels that is supplying the anterior segment, the lens, and the iris, the cornea. These are should regress in the third trimester, but sometimes if they don't regress, they can result in what's called persistent fetal vasculature, as we said in the pediatric ophthalmology. Regarding the physiology of the lens is one of the metabolically active tissues in the body, and they require oxygen in order to keep its transparency. And in order to become transparent, there is a certain physiological process and equilibrium that should be present in the lens. Like the lens, they will have high water content, they will have high sodium, or if there is any, if these are the physiological processes which will cause cataractogenesis, which will cause cataract formation. If there is increasing water content in the lens, or if there is sodium content, which indicates the problem in the sodium potassium ATPase pump, if there is increasing calcium, which will cause cortical cataract, if there is increase on soluble proteins, which will increase with life, this will also cause increasing the cataract formation. Or if there is decrease in the potassium or some enzymes which will be responsible for glutathione formation. The glutathione is the main antioxidant in the lens, followed by the ascorbic acid, which is another antioxidant in the lens. And if there is decreased ATP, all these, if they are decreasing, they can result in cataract formation. So just wanted to point out to these basic information, because even sometimes they are asked in the clinical exam. Let's now jump immediately to the main bulk of the lecture, which is the lens disorders and the cataract. Let's first start with the very important and common kinds of cataract, which are the senile cataract. What is the senile cataract? The senile cataract, there will be, it is the cataract which occurs more as an aging process. These cataract, they are different types. We have the nuclear, the cortical, the posterior subcapsular, other types. These are the main types of senile cataract. So cataract is an opacification of the lens. So why the nuclear cataract? This nuclear cataract, you can see it appears as a yellowish or brownish discoloration of the lens. You can see the lens here. This is where is the nucleus. That's why it's called a nuclear. It affected the nucleus. There is opaqueness, there is cloudiness of the nucleus, which appears as yellowish color. Why it appears yellowish in color? Because the nuclear cataract results from a process called the deamidation of the lens protein, which occurs by oxidation and the glycation. These result in some products. These products will result in formation of what's called the urochrome pigment. This urochrome pigment, when the light is falling on it, this will result in a scattering of light. This is scattering which will give rise to this yellowish coloration. Also, this is an important thing, that those patients with nuclear cataract, they may show what's called index myopia. What is index myopia? There is myopic shift. They will show myopic shift in refractive error because of the stiffness of the nuclear matter in the nucleus, resulting in that they will refract the light more, resulting in more myopic or more powerful eye, more powerful refraction, leading to more myopic shift. So this will be a feature of nuclear cataract. This is very important also for the MCQ. I'm stressing on things that are important for the MCQs. Sometimes when the lens is growing older, like if the patient is growing older, he didn't do the cataract surgery, this yellowish color is turned to brownish color. And in this case, the nucleus is termed as brunescent cataract. So brunescent cataract is very mature lens, very hard nuclear cataract, which occurs due to opaqueness of the nuclear fiber. So this will be like extreme form of the nuclear cataract. Okay, and as we mentioned, this occurs as an age-related process. There is a progressive yellowness and hardness of the lens, and resulting in this appearance of hard cataract. Okay, so what will be the symptoms of those patients? They will complain of diminution of vision. They will complain sometimes from monoocular diplopia. They will be unable to differentiate the colors, and sometimes, and this is also important for you, that in the exam there are patients could have surprisingly good visual acuity despite dense cataract. So not all patients will have very poor visual acuity in nuclear cataract. It could have that those patients could have good visual acuity. Okay. So to summarize, the nuclear cataract, it is mainly occurs due to that the appears in the nucleus. Why it appears in the nucleus? Because the nucleus is away, it is in the center, so it is away from the aqueous and the vitreous, and those are the sources where the lens is acquiring the glutathione, the reduced glutathione, which is or they acquire the glutathione, then this will be coming to the cortex. Then they reduce the glutathione will be deficient till it reaches the center of the nucleus or the nucleus itself. So those patients or the lack of antioxidants as an aging process and the lack of glutathione and ascorbic acid is one of the main reasons for nuclear cataract formation. Another good thing about the nuclear cataract or an advantage of nuclear cataract is that it can sometimes improve the patient visual acuity in near, like those patients who the nuclear cataract occur due to age relation or age-related process. So those patients after 40 years of old, they develop what's called presbyopia or recession of the near point. They will have problems in near vision. This is because of weakness of the lens. But what happens if they develop nuclear cataract? They will regain the power of the lens by this myopic shift, resulting in that those patients who use to complain from reading or near tasks, they will be having very good vision for near tasks. So this is again a character for nuclear cataract, the myopic shift. This is important for the MCQs. Okay. The next type of cataract is the cortical cataract. Cortical cataract appears as spikes. It appears as whitish spikes or spokes present in the periphery, and they are usually associated with a swollen lens. And those are due to opacification of the cortex. So they are problems in the cortex. You can detect it by retroillumination or by direct illumination or by oblique illumination. So actually the cortical cataract occurs due to imbalance, electrolyte imbalance. So this electrolyte imbalance is what will result in overhydration of the lens or swelling of the lens. This will cause liquefaction of the lens fibers. So clinically, they appears as presence of vacuoles, clefts, wedges, or lamellar separation of the lens fibers. And they can be either partial, can be complete opacification of the cortical fibers, and it could be congenital, could be infantile or senile, but here we are presenting the senile. Present with these wedge-shaped opacities, can be anterior or posterior, and then these opacities tend to progressively worsen over time. Okay. So these are called the cortical cataract. So to summarize, what is important about cortical cataract? It is due to characterized by overhydration of the lens due to electrolyte imbalance. So it could also be related to increased calcium, intralenticulaar calcium. This imbalance will result in increasing calcium within the lens, and characterized by presence of vacuoles, clefts, and wedges. The third type of senile cataract is the posterior subcapsular cataract. So it is an age-related process as well. It is developing in the area, subcapsular area in posterior capsule. So it appears as granular opacities. These can be central, can be diffuse, and we grade the grading of posterior subcapsular cataract depending on its spread, how much it is spread. It's taking 1 quadrant, 2 quadrant, 3 or 4 quadrants. Okay, so these are here the posterior capsular is developing because of the loss of lens fibers or the loss of lens fibers nuclei, and they're becoming replaced by abnormal epithelial cells toward the posterior pole. These epithelial cells are clusters forming balloon cells. They are interdigitate with the lens fibers and causing these granular opalescent opacities like that. So these are irregular, refractile, crystalline opacities usually present in the central posterior pole, and that's why they are affecting the vision, because they are present usually in the posterior pole. They can sometimes be idiopathic or can be secondary to irradiation or trauma. These are common causes, but also chronic steroid. Those patients who are on long-term steroids for any systematic disease, these steroids are making the patient prone to the risk of developing cataract. Which kind of cataract? It is the posterior subcapsular cataract. Also, prior intraocular surgery like barzoplantar vitrectomy also causes this posterior subcapsular cataract. And here is a trick in the MCQs. The barzoplantar vitrectomy put the patient at risk of posterior subcapsular cataract. So this will be the commonest for barzoplantar vitrectomy. But if the patient had barzoplantar vitrectomy with a silicone oil implantation, the most common cause of cataract, or the most common type of cataract, will be the nuclear cataract. Okay, got it? Barzoplantar vitrectomy alone will cause posterior subcapsular cataract. Barzoplantar vitrectomy with the silicone oil implantation will cause nuclear cataract. So this kind of cataract tend to progress very rapidly. The posterior subcapsular progress very rapidly, and will cause more visual debilitation. So unlike, for example, the cortical cataract, as it is more peripheral. Okay, this is for the posterior subcapsular cataract. When the entire cortex, if the patient has liquefied cortex, you see the patient has a liquefied cortex, and this cortex become totally liquefied, and then the nucleus become totally white and opaque. Then in this case, we call that this is a mature cataract. So you see this wedges with cleft vacuole of the cortical cataract. This is a cortical cataract. And then when the total cortex, there is no cortex here anymore. There is the whole cortex is liquefied, leaving only the nuclear in the middle. When this happens, when there is total liquefaction of the cortex, then the cornea, then the lens become totally white and swollen. And in this case, we call it mature cataract. Okay. So in mature cataract, the lens become mature or whitish and absorb the water. So the lens absorbs the water, becoming swollen, becoming enlarged. Sometimes we call it an intumescent cortical cataract. And this can result in some challenges in the surgery, and also can result in that this intumescent cataract, this swollen cataract, will push the iris in front of the angle, leading to what's called phaco-morphic glaucoma. It will result in angle closure by this swollen lens, which will push the iris. It's called phaco-morphic glaucoma. We will discuss it in the glaucoma, but now you understand what is its base. So intumescent cortical cataract may lead to angle closure glaucoma. This is very important. When there is the degenerated cortical material leaks out of the lens capsule, this will result in the capsule becoming shrinked, and the nucleus will sink down in the capsule. This will result in what's called hypermature cortical cataract. So hypermature cortical cataract is when the process is continuing, like the patient has degeneration of the cortical material, and this degeneration of the cortical material will leak out of the lens capsule. So the lens will lose its volume, and there can sometimes be present with calcification. There is calcium deposits, resulting in that the lens is losing its volume, so it will the capsule will become shrunken. This is called hypermature cataract, and the hypermature cataract is associated with another kind of glaucoma. What is this kind? It is an open angle glaucoma called phacolytic glaucoma. What is meant by that? When the patient has hypermature cataract and this abnormal lens protein are leaking out from the intact capsule, this will result in that they will be engulfed by the macrophages present in the anterior chamber, and they will precipitate into the angle of the anterior chamber, resulting in high intraocular pressure, what is called phacolytic glaucoma. So this is another kind of lens-induced glaucoma that you are aware of right now. When there is further liquefaction, when there is further liquefaction of the cortex, then there will be free movement of the lens or the nucleus within the capsular bag. This is another scenario where the nucleus becoming freely mobile and sink down into the nuclear bag. And in this case, it is called Morganian cataract. It is Morganian cataract where the nucleus is sinking down into the bag. So this will be how does it looks like. So Morganian cataract as well can lead to faculated glaucoma, as there is can be diffusion of the lens proteins from the intact lens capsule. Okay, so these are the senile cataract that we have. Let's now talk about the congenital cataract. So remember this, what does this picture remind you of? It is the persistent hyaloid vessels, persistent hyaloid vasculature. So this is the lens, and this is the persistent hyaloid vessels. And what is this? This is the attachment of the hyaloid vessels on the back of the lens. This is called the Mittendorf dot. So Mittendorf dot is a dense white spot located into the infranasal. It is infranasal dot to the posterior capsule. This is asked in the MCQs. Infranasal dot to the posterior capsule of the lens. And it is present due to remnants of tunica vasculosa lentis. So remnants of the posterior pupillary membrane of the tunica vasculosa lentis, and it will mark the site or location of where the hyaloid artery used to be in contact with the posterior surface of the lens. So when you see this, you may be worried that this patient could have the remnants of posterior hyaloid that can be either total or partial, as we mentioned in the pediatric ophthalmology. Another congenital form of congenital lens opacities is called the epicapsular star. This is actually a very common condition, which will be there will be again remnants of the tunica vasculosa lentis. It's called the epicapsular star. So as the name suggests, you have this anomaly present as a star-shaped configuration of brownish or golden flecks present in the central anterior lens capsule. So it is present in the central anterior lens capsule, golden flecks at the central anterior lens capsule. This is very important. I'm asking in the exams, where is the location? It is either in the anterior or posterior. The epicapsular star is in the anterior center. The Mittendorf dot is in the posterior lower nasal. Okay. A third congenital anomaly related to the lens is called the lens coloboma. So a coloboma is there is anomaly in the shape. So there is like a wedge-shaped defect present in the lens or indentation of the lens like that. So this is like those patients have like primary. This is a primary lens coloboma. Sometimes the coloboma could be secondary, like after trauma or if there is ciliary body tumor. And these lens coloboma typically are present infranasal. Infranasal. This is very important, as any coloboma is like the choroidal coloboma, the optic disc coloboma, chorioretinal coloboma. All the colobomas tend to be lower nasal, as this is the location of closure of the embryonic fissure. Okay, so it could be primary or secondary. It is infranasal, associated with coloboma of the iris, optic nerve, and retina. Lenticonus, as we mentioned in the pediatric ophthalmology. So why I'm bringing here, because it's asked in the ICO in both pediatric ophthalmology and also in the lens. So as we mentioned, it could be either anterior or posterior. It is a conical shaped deformity or central bulge either in the anterior lens capsule or posterior lens capsule, or in the anterior lens or posterior lens, characterized by high astigmatism. The anterior tend to be more bilateral, while the posterior more unilateral. Anterior, it is more in males than females, while the posterior, it is more in females than in males. Posterior tends to be more sporadic. Anterior can be associated with Alport syndrome, which is characterized by presence of anterior lenticonus, hereditary nephritis, and deafness, while the posterior characterized there is the amblyopia is more common. Another form of a congenital cataract is called the lamellar cataract or zonular cataract. So what is what this is actually, it is the commonest congenital cataract. So if they asks you about what is the commonest congenital cataract, it is the lamellar or the zonular cataract. They tend to be bilateral and symmetrical, and actually their effect on the vision or their effect on the vision is variable depending on the size and the density of the opacity. So not all cases will be affecting the vision. Can sometimes be autosomal dominant trait or can be inherited, and it can be sometimes, this is what is asked in the exams before, can be sometimes a result of transient toxic substance in the embryonic lens development. Like if the mother is exposed to transient toxin during the during the pregnancy, this can result in that the baby will suffer from lamellar or zonular cataract. And the more the early this toxic influence occur, then the smaller and the deeper this lamellar cataract occur. So this is the commonest congenital cataract. I'm just highlighting the most important things here. It is the commonest congenital cataract. It may be due to transient toxins of the embryonic lens. Another form of the cataract is called the sutural cataract. In sutural cataract is a cataract, there is opacification of the Y suture present in the fetal nucleus, as we just mentioned in the anatomy. They don't impair the vision or they don't affect the vision. Appears as branches that with projections, as you can see them. These are usually bilateral, usually symmetrical, and also inherited as autosomal dominant pattern. So what is most important here is that they don't affect the vision. Another kind of congenital cataract is the blue dot cataract, or sometimes referred to as cerulean cataract. So blue dot cataract, again, is one of the common types of congenital cataract which does not affect the vision. These are the specifically asked in the MCQ exams. Blue dot cataract doesn't affect the vision. Another kind of cataract is the polar cataract. So the polar cataract are the lens opacities involve either the anterior pole or the posterior pole. It can be subcapsular. It is a subcapsular opacities involving the area, the cortex, and the capsule of the anterior or posterior pole. There is a huge difference between the anterior polar cataract and the posterior polar cataract. Let's start first by the anterior polar. The anterior polar tend to be more small, more bilateral, more symmetrical, and non-progressive. So these opacities usually don't affect the vision. So they can be congenital, can be sporadic, can be inherited, can be autosomal dominant, and they can be associated with other congenital anomalies of the eye, such as microphthalmos and persistent pupillary membrane, and usually they do not require treatment. But sometimes they cause anisometropia. So here, concentrate. Those patients usually don't have poor vision from that the opacity is occluding the visual axis. They don't have sensory deprivation, but this can cause, somehow it can cause anisometropia. So this is the commonest cause of loss of vision for patients with anterior polar cataract. On the other hand, the posterior polar cataract, it can be small, can be large like that, and it is a central opacities. It is usually doesn't increase in size over time. It is usually bilateral, or the posterior polar cataract is present at the posterior capsule. They will be more visually significant than the anterior polar cataract. So those patients with posterior polar cataract are usually complaining. and usually surgery are indicated, unlike patients with polar cataract, anteropolar cataract. And also they will pose specific risks in the cataract surgery, as we are going to discuss in the phacoemulsification. They can result in, these patients will have defect in the posterior capsule, so they will be associated with more incidence of break of posterior capsule and what's called capsular blowout during hydrodissection, resulting in drop of the nucleus into the vitreous. Okay, so here are the important data about the polar cataract, that the anteropolar cataract usually doesn't affect the vision, and even when usually those patients, we don't do surgery for them for the anteropolar cataract, but it is just removed with the capsulorhexis during removing other kinds of cataracts such as nuclear or posterior subcapsular. Usually those patients have refractive error, which will result in anisometropia. On the other hand, patients with posterior polar cataract, those patients will have impairment of the vision, and it is more dense, more central, and those patients will be specific precautions during hydrodissection. During phacoemulsification is to avoid hydrodissection, to avoid rupture of posterior capsule. Another congenital condition about the lens, it is called the microspherophakia. Microspherophakia, the lens is, as the name implies, micro, small, sphero is spherical, phakia is the lens. So it is a small spherical lens. These are small spherical lens, usually bilateral condition. Usually you can find the zonule are visible on pupillary dilatation. There is also associated with iridogenesis or lack of lens support with the iris. So there is tremulous iris associated with a wide range of conditions such as Weill-Marchesiani syndrome, hyperlysinemia, Loewy syndrome, Alport syndrome, congenital rubella, Peters anomaly. So this is the problem of the microspherophakia, apart from the defective vision, is that it can prolapse into the anterior chamber, causing pupillary block. So that's why those patients with microspherophakia, myotics are contraindicated. This is asked in the MCQs. We do not use myotics in patients with microspherophakia. We use cycloplegics, and trying to and another question appeared before, where we do manual reposition by gentle tapping over the cornea, trying to reposit the lens into the posterior chamber. And also these patients should be candidate for lensectomy. This lens should be removed if the patient has more prone to develop angle closure, or if it's prolapsing in the anterior chamber, or if the patient has significant refractive error. So this will bring us to the term of ectopia lentis. So ectopia lentis means that it is a displacement of the lens. So the displacement of the lens, it could be either congenital or traumatic. Congenital will be all these collagen diseases and the other conditions such as Marfan syndrome, homocystinuria, aniridia, congenital glaucoma, Ehlers-Danlos syndrome, hyperlysinemia, Weill-Marchesiani syndrome, and the sulfite oxidase deficiency. These diseases characterized by displacement of the lens. For the acquired, the most common cause of acquired lens displacement will be the trauma. So this will be the trauma. All these are congenital, non-traumatic causes of ectopia lentis. So this is how does the ectopia lens appear. It could be either subluxated or luxated. Subluxated meaning that it is partially displaced from its normal position, but it is remaining into the pupillary area. This is meant by subluxation. It is partially displaced from its normal location, but it is still within the normal, within the pupillary area. But luxated is a total dislocation of the lens. It is a total dislocation of the lens. It could be either anterior into the anterior chamber, or dropped, it will be in the posterior chamber. So it will be a posterior dislocation. This means that a luxated lens, meaning that there is a total separation of the all zonular attachments. What are the complications of the ectopia lens? Well, an opacified lens or an abnormally located lens could opacify, so a cataract could develop, or there could be displacement of the lens into the anterior chamber, luxation of the anterior chamber, resulting in pupillary block, leading to pupillary block glaucoma, or it can be dislocated into the posterior chamber, so they can drop into the vitreous cavity. So those patients will not have, the problem of those patients will not have severe inflammation because the lens is dropping as a whole, so it is not opened, and there is no you know that the lens is an immune privilege site, so the lens proteins are sequestrated within the capsule all entire life. Once they come out of the lens capsule, they will induce immune reaction. But here, when the lens is dropping as a whole, then they will not induce immune reaction because the lens is contained within its capsule, but those patients could have a marked refractive error. Also, I told you that the glaucoma could be due to pupillary block. So it will be in this case, the lens or the eye will be injected. There will be pain. So because of high intraocular pressure. But in the posterior dislocation, there will be no pain. Some important collagen diseases will be associated with ectopia lentis, will be the Marfan syndrome. So patients with Marfan syndrome will have specific general features, like they will have limb trunk disproportion. They will have what's called long arm span. Long arm span. They will also have arachnodactyly, tall fingers resembling the spider fingers. They will have abnormal chest deformities in the form of what's called the pectus excavatum and high arched palate. They will have cardiac anomalies such as aortic dilatation, dissection, regurgitation, and the mitral valve prolapse. Regarding the ocular features of Marfan syndrome, they will have lens subluxation. This subluxation has very two important features. First of all, it is an upward subluxation. Is an upward subluxation. Usually it is upward and temporal subluxation. Also, those patients have the zonule are usually intact. Here are the zonule. The zonules are usually intact. They will have higher incidence of retinal detachment. They will have more lattice degeneration. They will have axial myopia. They will have angle anomaly and glaucoma. How also can present with cornea plana and blue sclera, as we mentioned earlier. This is one of the syndromes associated with ectopia lentis. The other syndrome is called Weill-Marchesiani syndrome. It has also systemic features and ocular features. Systemic features that they will unlike the Marfan syndrome. So the Marfan syndrome will be tall. These will be having short stature. The Marfan syndrome will be having arachnodactyly or tall fingers. Those will have short stubby fingers, sometimes referred to as brachydactyly. The Marfan syndrome will have normal mentality. The Weill-Marchesiani syndrome will have mental handicapness. So they have mental retardation. They have the whole reverse spectrum of systemic features. Regarding the ocular features, the Weill-Marchesiani syndrome will be characterized by presence of microspherophakia, and there is anterior lens subluxation, usually with angle anomaly and glaucoma. Another syndrome characterized by lens subluxation is called the homocystinuria. In the homocystinuria, they have characteristic systemic features. Those patients usually have malar flush, they have red face, they have fine hair, blonde hair, and they will also show some Marfanoid habituus, like can show some degree of mental retardation. They will also have increased platelet thickness. They have increased hypercoagulability state and mental handicapness. Regarding the ocular features, unlike the Marfan syndrome, which will cause upward subluxation of the lens, the homocystinuria usually show downward subluxation of the lens. And so the Marfan usually it is upward and temporal. The homocystinuria usually it is lower and nasal. And also another difference between the homocystinuria and the Marfan, that the Marfan has normal zonule, while in the homocystinuria, there is usually disintegration of the zonule. The zonules are not there. Okay, so these are the differences between these three diseases, very common to be asked in the exam. Regarding the treatment of the ectopia lentis, well, this will need like a series of lecture to discuss the treatment of ectopia lentis. But to try to summarize them, we have different lines depending on the patient's symptoms, the patient's complaint, and the surgeon's experience. So starting from the least invasive, glasses and contact lens, which will be reserved for patients who have good visual acuity, they are stable, they don't have glaucoma, so they don't have cataract. So the treatment in this stable condition will be glasses and contact lens. But if the patient has cataract, then the lens has to be removed. How is the lens is removed? It can be removed in two, like to remove all the lens, lensectomy with vitrectomy, and visual rehabilitation by contact lens or spectacles. Or we can do implantation of the in the bag intraocular lens with a capsule tension ring, or we can implant in the bag with the help of capsular support, either with the capsule tension ring or Scioni ring or ring segments. This can be done in case of limited zonular dialysis or limited zonulopathy. So it depends on what is the degree of zonular dialysis and what is the degree of and what is the original pathology. Are the zonule are intact or not intact? So they can sometimes be visible, but they are not healthy, like in Marfan. So this will be the different techniques of removal of the lens, either lensectomy or to remove all the lens, or to do it like the routine way by capsulorhexis and removal of the lens. And for the implantation, we can either implant a lens in the bag with the capsular support, or we can implant an iris supported lens such as Artisan or Artiflex, or the iris supported Clo lens, or we can implant a scleral sutured posterior intraocular lens. So scleral fixation intraocular lens also can be done if there is no capsular support. And of course, there will be no capsular support in such conditions. And if there is no iris supported lens is feasible. So what I'm just telling you here, that not every patient will fit into the same category. So the decision to remove the lens should be always individualized. It can sometimes be necessary, can sometimes be like for case of cataract or for case of glaucoma, where it is displacing into the anterior chamber. Sometimes it can be not necessary, so we can just follow up with refractive correction by glasses or contact lens. So this will be the how would we do management of patient with ectopia lens. Dr. Yahya, Marfan dominant? Yes, Marfan is autosomal dominant. And for the homocystinuria and the Weimar-Chiziane syndrome, they are autosomal recessive. So these are the different scenarios. So if you have a patient with mild displacement of the lens, whether still they have good visual acuity, like if they have like -2, -3 slender that can be corrected by glasses, they are not complaining, the lens is in place within the pupillary plane and no problem, they can be just managed to be, can be managed conservatively, like by glasses or by contact lens. But look here, this patient has hugely displaced displaced the lens, marked ectopia lentis. The lens edge is bisecting the pupil. So this patient mostly will complain of diminution of vision and monoocular diplopia. He will be able to see through this lens and through this aphakic part. So in this case, the lens should be removed. Here again, the lens is luxated into the anterior chamber, and this patient is prone to pupillary block. So as you can see that the doctor here is giving, or the ophthalmologist giving him cycloplegic and the mydriatic drops in order to dilate the pupil. We can do conservative management if the patient is uncooperative by gentle tapping over the cornea and trying to manually reposit the lens into the posterior chamber. But the better is to remove. Here is a patient with subluxated ectopia lentis, but it is totally dislocated into the vitreous. So those patients will need vitrectomy. Those patients will need vitrectomy and the removal of this lens. This patient has angle closure because of the pupillary block. So those patients, we need to, first of all, medically manage those patients by aquasuppressants and anti-glucomatous medications to control the inflammation. Then we admit the patient in the surgery to remove the lens. This is a patient who had cataractus dislocated lens. So those patients should remove the lens because of the cataract and because of the dislocation. So you can see how every scenario is different. Every scenario in the ectopia lens, I took me time to prepare this slide to just tell you. For many, in the previous years, always you tend to ask me how to manage a patient with ectopia lentis. The scenario is to say, would we do in this case of ectopia lentis? There is no treatment that fits all cases. It will always depend on the scenario. It will always depend on what is the presentation and what is the patient's complaint. Okay, so we finished the senile and the congenital conditions. Now we will move to the trauma. So what will be the traumatic condition affecting the lens? Well, it could be the patient is subjected to blunt trauma or blunt injury causing impression of ring of pigments on the anterior surface of the lens. This ring of pigments is called the Vossius ring. Vossius ring is an imprint of the iris pigments over the anterior surface of the lens. So it is usually visually insignificant and usually resolve with time. But it is just when you see it, you just know what is the history, that the patient had history of trauma, history of blunt trauma. Another manifestation of blunt trauma will be this cataract, this rosette-shaped cataract. Rosette-shaped opacification is a result of blunt trauma, which will result in this characteristic pattern of rosette-shaped cataract, sometimes referred as stellate cataract or rosette-shaped cataract. It is usually present in the center or in axial end location, usually involved with a posterior lens capsule. And as you can see, it will be, it can be apart from other manifestations of blunt trauma. So it can be associated with a lens dislocation. It can be associated with cataract formation. So usually it will need surgery, or it will need to remove, or it will affect the vision. But not in all cases, in very few cases, or in rare cases, if there is mild cataract, mild contusion cataract, can improve spontaneously, but this is not the rule. Another sign of trauma will be traumatic dislocation. So traumatic dislocation, like if there is a blunt injury, this will result in a trauma that will cause damage to the zonule, leading to dislocation of the lens. As you can see here, it is dislocated. There is subluxation of the lens, and it can be luxated into the anterior or posterior, as we mentioned. So it can become anterior to the iris, or it can drop into the vitreous. This will be signs of trauma resulting in this dislocation. So those patients will complain of diminution of vision, impairment of the accommodation. They will also complain of diplopia. There will be high astigmatism. When you examine the lens and the iris, you will find that there is iridogenesis are present. So the anterior dislocation can lead to pupillary block, as we just mentioned. Another form of injury is the chemical injury, as we discussed it in the cornea. So actually the chemical injury also can cause cataract. So if there is penetration of the cornea until the chemical agent reach the lens, it will result in cataract. So which one we said that it will have more tendency to penetrate? Which one will cause more tendency to perforate or to penetrate through the cornea and reach the anterior chamber? It will be the alkali. So the alkali will tend to cause more injury to the lens than the acid because it tends to penetrate more. So why this also asked before in the exams? Why it is causing a cataract? Because actually it will increase the aqueous pH. And this increase in the aqueous pH will result in decrease in the level of aqueous glucose and ascorbate. So this will result in the development of cataract. Okay, so again, chemical injury, more common with the alkali than acid injury. It will result in increasing in the aqueous pH and decreasing in the level of aqueous glucose and ascorbate, resulting in cataract. Another presentation of trauma will be the penetrating injury. A penetrating or perforating injury of the lens will cause opacification of the cortex at the site of the rupture or at the site of the injury. You can see here this. Actually, sometimes a small perforation can heal, resulting in like stationary cortical cataract. Sometimes, but in many occasions, it can progress. So penetrating injury to the lens can progress to involve the opacification of the whole lens, but in some occasions, it can be, if it is small and localized, it can cause local cataract, local cortical cataract, and it becomes stationary. So it is usually progressed to complete opacification, but may result in stationary focal cortical cataract. Another form of penetrating injury is, you see this? What is this? There is a trauma, penetrating trauma, resulting in rupture of the anterior capsule, and there is leakage of lens, or there is exposure of the lens into the anterior chamber and posterior chamber. So if the trauma is massive, if trauma is severe, leading to opening of the anterior lens capsule and then the whole lens now is exposed, then this will result in inducing severe immune reaction, as I told you, because of that the lens proteins are antigenic, resulting in antigen antibody reaction, which will result in antigen antibody complexes that will be deposited into the angle, resulting in what's called phacoantigenic glaucoma, which was previously termed as phacoanaphylactic glaucoma. But now this term is not correct. So it is now called the phacoantigenic glaucoma, and this is the third type of lens-induced glaucoma, with the phacolytic and the phacomorphic glaucoma. It's caused by occurs after trauma or after surgery due to exposure of the immune system to the lens proteins. Okay, so these are the traumatic causes of cataract and traumatic condition affecting the lens. Let's now talk about the metabolic. The metabolic, starting by the diabetes. So diabetes can cause, is one of the commonest cause of changes in the refractive error. So how does the diabetes, or what is the effect of the diabetes on the lens, and how does it affect the refractive error? Let me explain this to you. If a patient has hyperglycemia, then this will result in hyperosmolarity. Hyperosmolarity meaning that the vitreous will contain more sugar. Okay, so the vitreous will contain more sugar, hyperosmolarity of the vitreous. Then this by osmolarity, this will result in that this sugar will go to the lens will absorb the sugar, and this absorption of the sugar will take water with it. So this will result in hydration of the cortex because it acquires the glucose from the vitreous, and this glucose will attract the fluid, attract water from it. So this will result in hydration of the cortex. If you remember from the optics, the cortex is acting as a minus lens. Its shape making it acting as a minus lens. So if there is hydration of the cortex, this means that this water will make the cortex less dense, making it decrease in the refractive index. And since that the cortex act as a minus lens, so a decrease in the refractive index of the minus lens will make the eye more powerful, leading to more refractive power, leading to more myopia. You got it? If you lost, let us explain it by the example of hypoglycemia. If a patient has hypoglycemia, like if he took his insulin dose and he didn't eat, so he has hypoglycemia right now. So this hypoglycemia will result in hypoosmolarity. The vitreous will have less glucose, so it will be hypoosmolar. So by osmolarity, the lens will have more glucose than the vitreous. So the glucose will travel from the lens, from the cortex, which is in contact with the vitreous, from the cortex to the vitreous. And passively, the water will pass from the cortex to the vitreous. So there is decreasing water in the cortex, resulting in dehydration of the cortex. And since that the cortex acts as a minus lens, so dehydration of the cortex will result in that the cortical fibers become more compact, leading to it is have more refractive index. So if increasing the refractive index or increasing the power of a minus lens will cause decrease of the overall power of the eye or a hyperopic shift. This is just for you to understand what is happening. But for the exam, what is asked is hyperglycemia causing myopic shift, hypoglycemia causing hyperopic shift. Okay. So this is the diabetes. But could diabetes cause any other problems in the eye or in the lens apart from change in the refractive error by myopia or hyperopia? Yes, it can cause a specific kind of cataract. It is called the snowflake cataract. So snowflake cataract is a multiple grayish white subcapsular opacities that have a snowflake configuration that are usually seen initially in the superficial anterior and posterior lens cortex. So this also occurs due to disturbance in the metabolism of the lens. So this due to increase the glucose level, this will result in the development of this kind of cataract. Usually bilateral, it is usually widespread subcapsular opacities, usually occurs of sudden onset and usually occur in the young individuals with uncontrolled diabetes. Another form of cataract which occurs due to metabolic disorders, it is called the galactosemia. A galactosemia, it is an autosomal recessive disease characterized by abnormal enzymes or lack enzymatic deficiency, so that the galactose is accumulating in the body. There is no enzymes that will convert the galactose to glucose. So the body is unable to consume or to metabolize this excessive galactose, resulting in accumulation of galactose in different body organs. One of them is the lens. Okay, so what will be the effect? Here is very important. It will cause a characteristic shape of cataract. It's called the oil droplet cataract. Oil droplet cataract is a cataract which caused by galactosemia. And also those patients who they have galactose deposition in their own in their different parts of the body, so they will suffer from malnutrition, they will suffer from hepatomegaly, jaundice, and intellectual disability. Another form of cataract is called occurs in myotonic dystrophy. Myotonic dystrophy is an autosomal dominant condition. There is abnormality in the muscles that they are characterized by delayed relaxation after contraction. Not only that, but also they have ptosis, they have weakness of the facial muscles, so that they have what's called expressionless face or mourning face or sad face because of the weakness of the facial muscles. Also, they have cardiac abnormalities, they have balding, you see this balding of the face. Of course, this is in males. And also they will have cardiac anomalies, as I told you. Regarding the cataract itself, they will have what's called polychromatic crystals in the lens, appears as like Christmas tree. So it is called the Christmas tree cataract. Christmas tree cataract is a polychromatic luster cataract which occurs in patients with myotonic dystrophy. Sometimes this will be associated with posterior subcapsular cataract and will proceed to complete cortical opacifications. Okay. Another kind of metabolic cataract is Wilson disease. Wilson disease is another disease called hepatolenticular degeneration, characterized by, it is autosomal recessive. It is an abnormality with copper deposition. So the copper, you remember I told you about this yesterday, about this ring. It's called the Kaiser-Fleischer ring. It is iron deposition within the desmus membrane present in the Wilson disease. So copper deposition occurs in different parts of the body, occurs in the basal ganglia in the brain, occurs in the liver, and also occur in the eye. In the eye, they occur in the cornea, leading to Kaiser-Fleischer ring, and also occurs in the lens, resulting in what's called sunflower cataract. Sunflower cataract is another kind of cataract which occurs due to deposition of cataract, copper within the lens. It just usually doesn't cause a serious visual impairment. Here is the copper, the reddish brown. You can see that the lens here is reddish brown or brownish or reddish. This is due to deposition of the copper pigments in, or the metabolites of the copper into the anterior lens capsule and the subcapsular cortex. So this will result in appearance of as if it is a sunflower or petals of sunflower. Here it is, more obvious photo for the sunflower cataract. It appears as due to deposition of copper into the anterior lens capsule and subcapsular cortex. So the Wilson disease cataract and the myotonic dystrophy cataract are very common questions in the exams. Another form of cataract is the amiodarone, resulting from the amiodarone deposition. So we mentioned before that the amiodarone is one of the causes that will result in vortex keratopathy and will also cause optic neuropathy. So deposition of amiodarone in the cornea will result in vortex keratopathy or cornea verticillata. And also it is one of the differential diagnoses of toxic optic neuropathy. And regarding the lens, it will cause anterior subcapsular lens opacities, as you can see here. Let's now move to the drug-induced, or the what are the cataract which are caused by certain drugs. First of all, the corticosteroids. As we just mentioned, that the corticosteroids will cause posterior subcapsular cataract, and it is related to the dose and the treatment duration. So it doesn't happen to all patients, but it happens with any method of steroid administration. Like it can happen after oral, topical, inhalation, systemic, intravenous. And the more the larger the dose and the more the duration, the more the incidence of the development of cataract. Okay. So posterior subcapsular cataract occurs with any form of the drugs like oral, topical, inhalation, subconjunctival, intravitreal implants. All this can result in a posterior subcapsular cataract. Another important drug which is asked in the exam, this is the phenothiazines. The phenothiazines are antipsychotic medications. They will cause some pigmented deposits into the anterior lens epithelium like that with axial configuration. Anterior lens opacities with axial configuration. So the crystals or the deposits of these phenothiazines occurs at the anterior lens capsule. So the location is important, asked before in the exams. And again, this drug or this kind of opacity is dose dependent and duration dependent. So pigmented deposits into the anterior lens epithelium in an axial configuration. So this usually doesn't affect the vision, so usually visually insignificant. Regarding some toxicity or toxic substance, so the smoking was found to be the most evidence-based approved toxic substance that will cause cataract. Exposure to smoking or smoking has an important associations in ophthalmology, like smoking increase the incidence of age-related macular degeneration and increase the incidence of graves of ophthalmopathy and increase the incidence of Leber hereditary optic neuropathy and also increase the incidence of cataract. So there are certain diseases which the smoking play a major role in its development. So it is the established risk factor for nuclear and posterior subcapsular cataract. According to a study, we will discuss about it in the retina. It's called the Age-Related Eye Disease Study 1. It was found that vitamin deficiency have no role in the development of cataract. And there are certain risk factors, but they are not as strong as the smoking. But it was suggested that ultraviolet light exposure, diabetes mellitus, prolonged corticosteroid use, ocular trauma, high myopia, all these factors may be associated with increased incidence of cataract. Finally, some miscellaneous syndrome and associations with cataract or associations with the lens, the pseudoexfoliation syndrome. It is a disease that will be characterized by pseudoexfoliative material present in the anterior lens surface and into the iris, into the back of the cornea, and into the angle, and will be characterized by development of opacity, such as leading to cataract. The cataract in such conditions will be very challenging, as we are going to discuss in the surgical part. And also we will get back to it again into the glaucoma lectures because it will make the patient at high risk of developing secondary open angle glaucoma. It is almost one of the commonest reasons for secondary open angle glaucoma. Dr. Yahya, what is the type of cataract with diabetes? I told you it is the snowflake cataract. Another kind of some miscellaneous topics associated with cataract is the atopic dermatitis. So atopic dermatitis, it is a chronic dermatitis characterized by itching with increased level of immunoglobulin E and characterized by cataract formation. Cataract formation occurs in around 25% of atopic patients, and this cataract is bilateral and occurs in the second to third decade of life and take the form of shield-like cataract. Shield-like cataract, they are anterior subcapsular opacities, occurs resembling the shield and present in patients with atopic dermatitis. This was also asked before in the exams. Phacolytic glaucoma, as we just mentioned, the presence of lens particles in the anterior chamber due to diffusion through intact lens capsule will result in these lens particles present in the anterior chamber and resulting in glaucoma. It will occur with hypermature cataract, so the lens protein will leak through an intact capsule into the anterior chamber. Phacomorphic glaucoma, where the lens become more swollen, more intumescent, and so that the lens push the iris to close the angle, leading to secondary angle closure glaucoma. And finally, the phacoantigenic glaucoma, where there is opened lens capsule. It is not intact, it is the lens trauma or surgery with an open capsule. This will result in exposure of the immune system to these lens proteins, resulting in uveitis, resulting in glaucoma. So there will be anterior chamber cells, flare, kepias, occasionally developing glaucoma. So this happens after trauma with opened lens capsule. This also asked in the cataract section. Okay, so this will be the medical part of the related to the cataract or the lens and the cataract. So we have now remaining the lens surgery and the corneal surgery. This is what we discuss the next time. Thank you very much for your attention, and I hope that you enjoyed the lecture. and wish you all with you all the best with your study. So is anyone have any question? Is the lecture is or the today's lesson is easy? Okay, great to hear. Thank you very much. Okay, thanks a lot, and good night. See you next time, next Monday.